Hello everyone, I am Raheema Abdul Hameed, Tutor cum Cardiovascular Technologist from the Unit of Cardiovascular Technology, Yenepoya School of Allied Health Sciences. Today I will be discussing a topic called Double Chambered Right Ventricle, commonly abbreviated as DCRV. It is a form of congenital heart disease. By the end of this session, we will be able to define double chambered right ventricle, describe the morphology and classification of DCRV, enumerate the signs and symptoms of DCRV, explain the pathophysiology and diagnosis of a DCRV, and list out the treatment options available for DCRV. Moving on to the introduction, double chambered right ventricle or DCRV is a rare congenital heart defect which is characterized by the presence of an abnormal mid-cavity obstruction within the RV that divides the RV into two chambers, which causes a disruption in the normal circulation. By definition, double chambered right ventricle or DCRV can be defined as a form of congenital heart disease wherein a mid-cavity obstruction divides the right ventricle into a high pressure apical and a low pressure infundibular chamber. This is a diagrammatic representation of DCRV. What you see in blue is the right ventricle. You can see that in the middle there is an unusual obstruction that also causes a disruption in the blood flow within the right ventricle. We will move on to the classification of DCRV. Classification of DCRV is based on the type, location and severity of obstruction as well as the associated cardiac anomalies that you find along with DCRV. DCRV based on type of obstruction can be divided into two, type 1 and type 2. In type 1, the obstruction is caused by an anomalous muscle bundle which crosses the right ventricle. In type 2, the obstruction is caused by a septal and parietal muscular hypertrophy. Next classification is based on the location of obstruction within the right ventricle. There are three. The first one is a subpulmonary obstruction. That is what you see in the image attached. The second type of obstruction is the mid-ventricular obstruction and the third is the infundibular obstruction. The third type of classification is based on the severity of obstruction. This is based on degree of luminal narrowing which is caused by the obstruction, and it is classified into mild, moderate and severe. Next we will move on to the associated anomalies that you find along DCRV. The most common associated anomaly that you find along with DCRV is a VSD or a ventricular septal defect. You also find tetralogy of Fallot, subaortic stenosis, pulmonary valve abnormalities, atrial septal defect, tricuspid valve abnormalities or a double outlet right ventricle. We will move on to the pathophysiology of DCRV. The abnormal hypertrophied muscle bundles within the right ventricle creates varying degree of obstruction to the flow within the right ventricle and into the pulmonary artery. This obstruction over time leads to an increased pressure within the right ventricle, the right atrium and the venous circulation. Over time, the increased workload on the right ventricle can lead to RV hypertrophy, arrhythmias, heart failures and other complications. We will move on to the symptoms of DCRV. The clinical presentation varies depending on the severity of obstruction and the associated cardiac anomalies. Common clinical findings include exertional dyspnea, fatigue, palpitation, chest pain, cyanosis and signs of right heart failure in severe forms. Moving on to diagnosis. ECG findings may be non-specific but can show evidence of right ventricular hypertrophy, right axis deviation and signs of right atrial enlargement. Again, it is not specific for DCRV. X-ray may reveal cardiomegaly, increased pulmonary vascularity and signs of right heart failure. X-ray may reveal cardiomegaly, increased pulmonary vascularity and signs of right heart enlargement. Moving on to echocardiography. Transthoracic echocardiography is the initial diagnostic modality to demonstrate a DCRV and measure the intracardiac gradients, especially in pediatric patients. During systole, the space between the muscle bundles decrease and the obstruction to the flow is magnified, which can be quantified by the help of echocardiography. A turbulent flow pattern can be visualized using a color Doppler in either transthoracic or a transesophageal echocardiography, which depicts the severity of obstruction to the blood flow. Here, image A shows a 2D echocardiogram of a right ventricular obstruction, wherein you can see a mid-cavity obstruction within the RV. Image B is a color Doppler of the same patient, wherein a turbulent flow can be seen across the obstruction. Pulsed and continuous wave Doppler is used to measure the gradient across the hypertrophied muscle bundle and to quantify and compare the obstruction to the flow as time passes. Additional imaging methods such as transesophageal echocardiography, cardiac MRI or cardiac CT can also be used to quantify. Next, we will move on to cardiac catheterization. Cardiac catheterization may be performed to confirm the diagnosis, assess the hemodynamics and plan for surgical intervention if necessary. It can also help in measuring the pulmonary artery pressures, assess the degree of obstruction and evaluate the suitability for corrective surgery. We will move on to the management. Medical management is advised to control clinical symptoms. The current guidelines recommend considering surgical closure of the VSD with the resection of hypertrophied muscle bundles. Again, surgery is advised only for patients with moderate or greater right ventricular obstruction with symptoms of heart failure, exercise limitation or cyanosis. Looking into the summary of DCRV. DCRV is a rare congenital heart disease where the right ventricle is divided into two chambers by abnormal muscle bundles. It causes obstruction of the right ventricular outflow tract. DCRV often occurs with other CHDs like ventricular septal defects. Symptoms may include cyanosis, breathlessness, fatigue and heart murmurs. Diagnosis is confirmed by echocardiography or cardiac MRI and surgery is the main treatment in case of severe obstruction. These are my references. Thank you.